everyone, or good evening if you're in Norway. Thank you so much for joining us. This is our second week of the Global Child Health Lecture Series, and today we have a joint talk by Dr. Anneka Hooft, and she's a physician and has an MPH. She's also an assistant professor in pediatric emergency medicine at UCSF, and she does research projects primarily on non-malarial fever in East Africa. And is also analyzing antibiotic use and the integration of traditional medicine providers into the biomedical health system and healthcare seeking behavior and resource limited settings. For the trainees who are on as well, she's also spent a year in Malawi. That was with SEED, Anneka? Yeah. So if I don't know if you'll have some time or if that's into your talk, but maybe at the end, you could tell us a little bit about your experience with SEED as well. And then we also have Dr. Joel Manyahi, who I know and have worked with very closely for several years now. He's a physician and also a senior lecturer in microbiology at Muhimbili University of Health and Allied Sciences and a clinical microbiologist at Muhimbili. He has a PhD from the University of Bergen, which is where he is right now in Bergen. And his PhD thesis focused on antimicrobial resistance in people with HIV and the implications for infection prevention and control. His areas of research focus on the diagnosis of infectious diseases, antimicrobial resistance, and stewardship, as well as epidemiology, detection, surveillance, and resistance mechanisms. And he has more than 35 publications to date in peer-reviewed journals, and now is also head of the department. Correct? Yeah. Congratulations.
Yeah, thank you. Yeah.
And with that, I'll hand it over to you.
Awesome. Thanks, Teresa. I'm going to share my slides. Okay. All right. So hopefully everyone can see that okay. So like Teresa said, we're going to talk about stewardship, antimicrobial stewardship program. This is specific to pediatrics that we worked on together. Well, still are working on. It's still a work in progress at Muhimbili, which is a tertiary care center in Dar es Salaam, Tanzania. And just some disclosure. So this work was funded by a QI grant from Pfizer. So we did receive some support for that. And so overall, we're going to talk a little bit, just some background on kind of AMR globally and sort of what leading up to kind of why this work started, and then specifically focus on the burden of antimicrobial resistance, which we'll refer to as AMR during the talk in Tanzania. And then we'll talk about antimicrobial stewardship implementation at this hospital, and we'll use AMS sometimes to refer to antimicrobial stewardship. So just in general, for people who may not have had as much microbiology training, say as Joel has had, what antimicrobial resistance is. So it's a naturally acquired genetic modification of microorganisms. And this talk will be focusing primarily on bacteria, but other organisms like viruses, parasites, and fungi can also develop these modifications and essentially makes them resistant to antibiotics. And then excessive use of antimicrobials accelerates its pace and intensity, whether this is inappropriate use or just, maybe necessary, but unfortunately over time they develop these resistance mechanisms. And then overall AMR poses a huge threat to global health as infectious diseases are becoming more and more difficult to cure. And so this map here just shows some of the burden of AMR, and there's now been kind of better systems in place to estimate some of the deaths attributable to this, because obviously that's very complicated. And you can see that the majority of this burden is in Asia and also in Africa, so primarily in low middle income countries in these settings. And then you can see here, like Africa is very high, the deaths attributable per 100,000 to bacterial antimicrobial resistance. And, a lot of these are associated with excuse me, resistant bacteria in these settings. And this is for all ages, not just pediatrics. And just kind of emphasizing that despite the burden in these settings, obviously this affects everyone. So, particularly since most of our audience is in the United States, that, everything, how global our world has become and people crossing borders all the time, that a threat globally, as we've seen with COVID, can really quickly become a threat locally, and these bugs spread across the world pretty easily. So it's in our best interest to kind of have some awareness and try to combat AMR globally. And then some of the things that lead to this, so there's a lot of local factors. So resistance mechanisms are universal, but there's a lot of variation geographically in kind of what your setting is like that influence how quickly and what types of resistance develop. And then just again, like it's during this talk, we'll use LMICs referring to low middle income countries as defined by the World Bank. And so you can see, there's antibiotic consumption, obviously in certain places, access to clean water is an issue, sanitation, whether vaccines are widely available or how good the vaccine coverage is, and then what healthcare access people have. And then kind of systems-wide, consumption, but then access, and we'll talk about this specifically in Tanzania about, where people are able to get antibiotics, and then surveillance, so whether this is tracked and how it's tracked, and do we even know, what antibiotics people are using or what resistance is developing. And then a big part of this that we're not going to really touch on in this talk is antibiotic use outside of the healthcare system. So agriculture, aquaculture, like all of the antibiotics that get pumped into the animals and farms and for food and all of that is huge and a really big driver of resistance, but we're not going to focus on that today. And then there's been some studies looking at overuse and misuse of antibiotics, which is, as you can imagine, sometimes a little bit difficult to define, but showing that, a lot of patients that are admitted in LMICs have very high antimicrobial use. So this study showed that 50% of inpatients in Africa were receiving some kind of antimicrobial. And then in different regions, that this is not unique to LMICs. So, it's very high in various countries, including the US, where, we still are not great about being judicious with our antibiotic prescriptions. And even in Louisiana, they showed that 60% of patients got antibiotics for basically URIs, which is, not considered appropriate. And then on the other side of this, there's still an issue with getting people who need antibiotics for treatment. So a lot of people who need them in LMICs don't have access to essential antibiotics, and the burden of illness and deaths from infectious diseases is still really high. So from these treatable infections. And so this image is showing that, these big circles are places where presumably having better access or having treatment with antibiotics could have prevented some of these deaths. Tanzania is here, so it's not a huge circle, but obviously the burden of deaths from pneumonia is still high in all these countries, and a lot of these patients don't get antibiotics. And so there's a high percentage of potentially preventable deaths from pneumonia in kids under 5 that aren't getting antibiotics. And so the whole point of this is just basically showing, like, while we need to balance inappropriate consumption and try to curb AMR, we also need to increase access to appropriate antibiotics and, treat infections that need to be treated, and reduce the global burden of infectious disease and, child mortality attributable to these. And those two things together will help us, get rid of these bacteria and hopefully fight antimicrobial resistance. And then surveillance is an important part of this. So, we're familiar with like the CDC and some of our kind of governing bodies that help with this. And then obviously we have, like hospital level, we have stewardship programs, like both in Oakland and at UCSF on the West Bay side, we have ID physicians who are tracking this and pretty robust stewardship programs. In LMICs, this is often a lot more difficult. So, there aren't as many tracking systems that are easily available. A lot of places still don't have EMR, so they're, charting on paper, and then tracking that is, you have to have you have to have the resources to do that, and so that's often not easily available. And so they have a lot of these point prevalence, or people kind of going in and just trying to see, like, at this moment in time, how much antibiotic use is there, and kind of using that to extrapolate some of the burdens of AMR and overuse. And so it's really difficult, and kind of one of the reasons why we wanted to start this project and begin with surveillance. And so I'll turn it over to Joel, and he's going to talk about some of the specifics of resistance in antibiotic use in Tanzania. Oh, sorry, I have to talk about this one first. Just kidding. I'll cover the slide. So I just wanted to bring up on the provider end, kind of what some of the things that make it difficult for providers in these settings to decide when to prescribe antibiotics or not. And so, in most of these settings, they're using IMCI, which is the Integrated Management of Childhood Illness, or the guide from WHO on how to kind of evaluate and treat all childhood illness, not just infectious disease, but they have specific flow charts and guidelines for febrile illness and infectious disease presentation specifically. And so especially in lower level health centers where you're mostly dealing with undifferentiated providers, sometimes mid-level providers who may not have had specific training or extensive specialization in pediatrics, this is the go-to for them, and kind of how it walks people through how to kind of assess, and then what testing to do and how to manage a child who presents with fever and whatever other symptoms. At Muhimbili, it's a little different because they actually have pretty robust medical training program there, and so most patients are being evaluated by residents who are specializing in primarily emergency medicine on arrival. The provider who sees them on arrival, but also they have pediatric providers, so they have a pretty extensive cadre of medical providers there who are considered specialists. And so they probably, and then it's also a tertiary care center. So many of the patients, or the majority of the patients that they're seeing, have already been evaluated in a lower level health center and have been referred because they're either, failing treatment there, or have some sort of illness or, problem that needs to be addressed by a specialist, or they don't have the resources in the lower level health center and they're sending them to Muhimbili for, ICU level care or something like that. So this center is a little bit kind of outside because they, oftentimes are deviating from what IMCI would where IMCI kind of would end, because they're seeing, a lot more complicated patients and a lot more complicated infections. And they also have a lot more training to kind of, be able to do some more complicated medical decision making. But in general, as a provider in these settings, you're seeing patients with a huge overlap in symptoms. So you have, a giant differential, including, malaria and viral illnesses and bacterial illness. And, we don't have a great estimate of the burden of severe bacterial infection in these settings because of some of these issues with surveillance and tracking and all of that. But we know that it's probably higher than, than what we would see, say, in the US. And then diagnostics are not always available. So especially in lower level health centers, sometimes they're only limited to, say, a malaria rapid test, maybe an HIV rapid test, sometimes a point of care hemoglobin, and that's about it. And then medications and supplies can also be limited. So there's, frequent stockouts, and, you may not have your first line treatment for certain things. Like I said, the training and familiarity with pediatric patients can vary widely. Clinic volumes, so we know the ratio of patients to health workers in these settings is really high. And then, there's oftentimes shortages of health workers. There's, issues with people not getting paid and going on strike, all of that stuff. And then, like I said, the true prevalence of serious bacterial illness in these settings is not really well known. Okay, now I'll turn it over to Joel.
Thank you, Anneka. I would like to highlight, as Anneka explained, overuse and inappropriate use of antibiotics is one of the drivers for antimicrobial resistance. In Tanzania, mostly people will get antibiotic over the counter. We have this accredited drug dispensing outlet, So I can get antibiotic without any prescription, and even broad spectrum antibiotic can be obtained from the these drug shops. So all this drives antimicrobial resistance. Also, we have pharmacies. These are not well regulated. Also, they can sell all kind of antibiotic from access group, watch group, and even reserve. Sometimes antibiotic are not obtained without any prescription. Also, antibiotic can be obtained from private and healthcare facilities. So the issue is having a quality antibiotic. So that's is a major challenge. All this drive antimicrobial resistance. Next slide, please. Next slide. Yeah. So antimicrobial use is very common in healthcare setting in Tanzania. One study which is done in 6 different referral hospitals, it was noted that approximately more than 62% of inpatients were prescribed the antibiotic. And in this study, ceftriaxone was most commonly prescribed antibiotic. But interestingly, only 2 out of 591 patients who were prescribed antibiotic had culture and acidity testing performed. So you see, a majority of patients are given antibiotic empirically without evidence from microbiological investigation. Also, another study which was done in northern part of Tanzania, this was done in 2 healthcare facilities, Kilimanjaro Christian Medical Center and the other regional hospital. It was found that more than 44 patients were on antibiotic. And also in this study found that those patients who received surgical prophylaxis were prescribed for 3 days. And surgical prophylaxis is indicated to use antibiotic prior and stop soon after completion of surgery. But majority, like 57%, use antibiotic for more than 3 days. So all this drive emergence of antimicrobial resistance. Next slide, please. Yeah, and the burden of AMR in Tanzania is enormous, and this data from 2019 showed that 12,500 deaths were attributed to antimicrobial resistance. This means all these deaths were AMR infection were the cause of infection, and 54,000 deaths were associated with AMR. It means a patient had AMR infection and other comorbidities. And Tanzania is one of the countries with highest standardized mortality rate associated with antimicrobial infections. As you can see, this rate St. Pete is among the highest country with high burden of AMR mortality. Next slide. So addressing antimicrobial resistance in Tanzania, Tanzania adopted the National Action Plan, Global Action Plan on Antimicrobial Resistance. So on Global Action Plan for AMR, require the country to develop National Action Plan to address AMR. So likely Tanzania developed the first action plan 2017-2022, and then now we've developed a new action plan 2023 to 2025. In this action plan, it addresses 5 strategic objectives. One is surveillance of AMR and research. One is antimicrobial stewardship, and the other one is IPC, infection prevention control. Also, we have to increase awareness and education, and also research on discovery of new antimicrobial agents, part of the such objective which National Action Plan should address. Next. So interesting, Tanzania is implementing antimicrobial disease surveillance, and this is conducted we have network of 11 healthcare facilities, and they are reporting data to national level. So, and most of the data are coming from pediatrics. I don't have slide showing the contribution of sample, but most of the isolate are from pediatric, and you can see most of this slide shows a specific pattern of Klebsiella pneumoniae associated from bloodstream infection, trend for 3 years. You can see ceftriaxone, for example. Ceftriaxone in this light blue color. Ceftriaxone is commonly used, but throughout the 3 years, susceptibility to ceftriaxone was very low, from around 15%. From first year, second year was around 15, and the third year, susceptibility to of Klebsiella pneumoniae to ceftriaxone dropped. If you look at the Cipro, it's the green line. You see there's sharp decrease from 2021, 2022 susceptibility to ciprofloxacin. If you look at Klebsiella pneumoniae susceptibility to amikacin, also there's sharp decline in susceptibility of Klebsiella pneumoniae to amikacin, but meropenem, which is in the watch category of antibiotic, it shows most of these Klebsiella pneumoniae are susceptible to meropenem with susceptibility more than 80%. But we see now meropenem increasingly being used, so we might end up where ceftriaxone we are. Next slide. This slide shows a bit of staph aureus from bloodstream infection for 3 years to different antibiotic. You could see susceptibility to penicillin is very low. Yeah, it's below through all 3 years was below 15%. If you look at thromycin, also this is among the access group for antibiotic. Susceptibility to erythromycin also is very low. If you look Staphylococcus aureus susceptibility to cotrimoxazole, also is below. It started from 30%. There's a slight increase on susceptibility to 2022 at 40%. If you look at cefoxtin, if Staph aureus is susceptible to or is resistant to cefoxtin, it means they are MRSA. So also isolate which are MRSA are a very common cause of bloodstream infection. You see susceptibility to cefoxtin is decreasing, so means the resistance to cefoxtin is quite high. So in more than 50% of Staph aureus which are causing infection are MRSA. So ceftriaxone, which is commonly used, cannot work on this bacteria. Also, ciprofloxacin, you can see the trend. Interestingly, chlorphenicol is not being commonly used nowadays, but you see there's increasing trend of susceptibility to chlorphenicol. This is a reason. A reason could be for over time now, chlorphenicol is not being commonly used to treat most infection in Tanzania. Clindamycin as well, susceptibility is below 70% throughout the 3 years of the surveillance. Next slide. Next, so this I would like to present. Anneka, would you like to start with this slide?
Sure. So we're just going to talk about a little bit about our program and kind of how we started working on this. So just a little bit, sorry, a little bit more background. As Joel alluded to, that the government in Tanzania and the Ministry of Health developed an antimicrobial stewardship program for the whole country. And this kind of came out of a lot of push from the WHO recently to kind of facilitate more AMS programs in LMICs. And so they produced some literature on this and some guides to help. And one of these is this toolkit. And then they also have a policy now, and trying to kind of increase development of programs, particularly in LMICs, and distribute resources for this. And so one of the components, so we used a lot of these materials for the development of this program. And from these two things, there's this checklist and kind of the core things that you need for developing these programs. And you can see here, like, one of them is dedicated financial support for an action plan, which obviously in LMICs is probably one of the biggest challenges, because there just aren't a lot of resources and aren't a lot of funds available to just kind of shunt to a new program. And so Tanzania has invested some in this, but for this program in particular, Joel was the one who kind of started all of this and saw this grant call from Pfizer that was particularly aimed at antimicrobial stewardship and primarily in LMICs, and approached us about, hey, can we apply for this and start to develop this program. And so we were able to obtain some outside funding to kind of put towards this specifically in pediatrics, and kind of reestablish a program that had previously been attempted in Tanzania at Muhimbili. So they had an AMS program in the past, and it kind of died because there just wasn't a lot of support for it. And so Joel wanted to get this going again, and also kind of try to make it better than it was before. And then along the chain of where antibiotics are used, so obviously, there's this whole pathway of, antibiotics have to be developed and manufactured, et cetera. So anywhere along this line is where you could potentially affect antibiotic use. And so we're particularly interested in consumption, and then this program specifically is primarily focused on prescribing, and then I guess maybe a little bit on dispensing. So we're only, one small step in the pathway, and I guess, hopefully influencing appropriate use through that. And then
so I will proceed.
You can start here.
Yeah. So we are implementing this quality improvement project at Muhimbili National Store, as Anneka highlighted. Muhimbili is a national referral hospital for the country, Tanzania, and also is a teaching hospital for Muhimbili University and the Allied Science is where I work. The hospital has 2,000 bed capacity and sees almost 2,000 outpatient per day. And it has different departments, including emergency department. And the emergency department sees about 60,000 patients per year, and 25 of those patients are children, and approximately 60% are admitted. The hospital is a central pathology lab, which has different lab specialization like microbiology, hematology, pathology, chemistry, and also the microbiologists, they perform culture for almost all specimens. Next slide. So this is a nice picture I see. It's emergency department unit. So this is a nice picture which Anneka just highlighted is our emergency department unit. So our quality improvement project, it has 4 specific objectives. First, we are tracking antibiotic use at the emergency department and the pediatric ward, included only 2 pediatric ward because of the funds we have. We couldn't include all pediatric ward. And on tracking, we are looking on antibiotic use, indication, route administration, dosing, de-escalation or escalation of antibiotic, and if they are using lab result to stop or escalate antibiotics. And then also we are collecting data from microbiological culture sensitivity. Fortunate, the hospital is part of the surveillance network. So the hospital received, the country received the grant from Framing Fund. This is a fund from Department of Health in UK. So they are supporting the facilities with reagent and consumable and also equipment. So the facility now, Muhimbili, is able to perform culture and susceptibility. So we leverage that opportunity to collect data for culture and the sensitivity from blood and urine, so that we could develop antibiogram specifically for pediatric. And also we aimed at establishing pediatric antimicrobial stewardship committee. As Anneka said, our initial effort at the hospital, we established the hospital antimicrobial stewardship committee, which we gave term of reference, including reviewing lab results, also plan for performing AMOS round, but the committee was not active because of funding. So after we received Pfizer funding, we formed the pediatric specific antimicrobial stewardship committee, and committee were meeting regularly, once every month, is discussing data which we are collecting from this quantitative project. And also one of the objective was to provide training on antimicrobial use and general antimicrobial stewardship. So we are able to develop posters and education material. And also we did training for EMD staff, especially residents and the medical and the registrars and the interns. Next slide. So the committee, AMOS committee, included microbiologist, pharmacist, there are pediatric emergency physician, a physician from intensive care unit, both neonatal and the pediatric. Also on this team included registrars, medical officer, and resident. Also medical student also are part of the team which are implementing this quality improvement project. Next slide. So we did this a small survey at EMD to understand the knowledge regarding antimicrobial stewardship. So we interviewed 31 medical officers, intern and resident. Majority collectively new definition of antimicrobial resistance, and the 74% of them said they prescribe antibiotic for upper respiratory tract infection at least sometimes, and the 80% of its clinician and said that the world care worker givers or patient will be upset without providing antibiotics. So they'll give antibiotic to because parents they will worry, or patients won't feel comfortable if they are not given antibiotics. So they decide to give antibiotic because the whole patient will feel like if I've not given antibiotic, maybe I've not received the appropriate treatment. But and most could identify empirical treatment for common pediatric condition, but this empirical treatment are guided by WHO. We have what standard treatment guideline, which is based on WHO recommendation, not based on a local data. But majority could prescribe antibiotic based on a guideline. Next slide. So on tracking antibiotic use, both at EMD and at pediatric, we found that approximately 30% of pediatric emergency department visit are prescribed with antibiotic. And more than 30 patients admitted are given intravenous antibiotic, commonly ceftriaxone and metronidazole. And the most common indication for prescribing antibiotic is lower respiratory tract infection, and the prophylaxis with trauma, medical condition, and neoplasm being the second common indication of prescription of antibiotics. Next slide. So if you look at the common antibiotic which you are prescribing at Muhimbili Hospital are from the watch category of antibiotic. But WHO emphasizes that we should first start to prescribe access group, and then next we prescribe watch group and reserve group. So if you see our data, it shows most of antibiotic which we prescribe under watch group, and this watch group, they are easy to develop resistance compared to access group. So it should be recommended in most setting in a country, we should start with access and then watch and reserve. But because we don't have data, like Anneka said, we don't have surveillance to track down the common use of antibiotic, what are impact of using those antibiotics. So that's why we'll jump to watch. And now we are even moving to reserve. And this all drive emergence of antimicrobial resistance. Next slide.
And I just want to add briefly, because I think our audience may be less familiar with these classifications, just because we don't really talk about some of the WHO, I guess, material or literature on these things. And so as far as like what fits into what category, so like access is kind of the more narrow spectrum, like amoxicillin, like very, less broad spectrum antibiotics, kind of less powerful. And then watch includes like ceftriaxone, kind of middle tier, a lot of what we use frequently in our hospitals, especially for sepsis. And then reserve is pretty high, I would say, like high level, very broad spectrum, like kind of what's now on the list of things where you give them only if patients are resistant to almost everything else. So actually at Muhimbili and in Tanzania, I think it's pretty difficult to even find reserve antibiotics. Like a lot of these are only available in higher resource settings because they're starting to become the like last line sort of treatments that we have available when the more common antibiotics are failing. So even in the watch category contains, things that you would think of as pretty broad spectrum, like meropenem. And then like he was saying, ceftriaxone is the most common, and then typically the WHO wants you to start with access and like start with kind of, especially for like outpatient treatment and that kind of thing, and then move up the line. And then for patients who are admitted, maybe broaden coverage based on your culture results. In patients who are septic or kind of higher risk, and starting with something more broad spectrum or maybe in the watch category, and then later narrowing as you get culture results back and kind of weighing your risk benefit depending on how the patient presents. And actually, I can talk about this part too, I think. And so when we were looking at this, we were trying to figure out kind of why ceftriaxone use was so high, especially in respiratory infections, and also prophylaxis, because we were, looking at these, and like a lot of these cases are like trauma, and sometimes it wouldn't even be like a traumatic, like it wouldn't even necessarily be someone who was needing the OR for trauma. It would just be someone who had like a severe head injury and was being, monitored and observed. And so what we found is, after some time in talking to the staff there, is that, I think several years ago, they created a sepsis guideline for the emergency department. And this is sort of the universal guideline for all emergency patients. Can you guys hear me? Okay, sorry, it looks like Joel was frozen, so I was afraid I was frozen. Okay, so this guideline is used for kind of anyone presenting to the emergency department, and there aren't really specific guidelines per source of infection. And so anyone who kind of meets, greater than 2 SIRS criteria, which you can imagine is pretty much any child with a fever, they get kind of put on this pathway, and the first line antibiotic is ceftriaxone and then metronidazole. Not every patient gets metronidazole, but pretty much everyone that fits on this pathway is given ceftriaxone, and then vancomycin is supposed to be added if they're immune compromised, and if it's available. I would say not very widely used, and I think part of that is because it hasn't been easily available. And then it says adjust based on lab results, but in the emergency department, this is like the empiric pathway, and then from there they go on to the ward, and then usually patients on the ward stay on what they were given in the emergency department. So ceftriaxone use continues there as well. And so we'll talk a little bit about what we're trying to do from here on that side. And then one of the other components of the project that we worked on was trying to get more information out to patients and caregivers, and try to have some posters and things available in the emergency department to explain the difference between, like, this poster was focused on bacteria versus viruses, and everything was translated to Swahili, and it had like more like these comparisons of like what types of illnesses are bacteria, what types are viruses, like in very pretty simplified terms for a layperson to read. And then this one is talking about like getting antibiotics and kind of when you need antibiotics versus not, and then how sometimes like the 2 pathways, like this is all in Swahili, so probably the only person who can read it is Joel, but this side is showing like this is the way you go. Like if you have a bacterial infection, you go to the doctor and they give you antibiotics and you get better. This is what happens if you don't have a bacterial infection and you get antibiotics, and like then you can grow resistant bacteria, and this can spread. And so just kind of like trying to increase awareness about when it's maybe not appropriate, and that not every infection needs antibiotics. And then these are now posted around the emergency department. And then for providers, as Joel mentioned, we had a couple of training sessions, particularly with the residents in the emergency department, and then developed this checklist of kind of things that they should be thinking about when they prescribe antibiotics. And obviously, we've figured out that even with some of these things, as the survey showed, a lot of our trainees and providers know about antimicrobial resistance and know that probably giving more narrow spectrum antibiotics is better, but the sepsis guidelines tell them to give ceftriaxone, and so they're still following the guidelines. And particularly with trainees, there's a lot of fear of repercussion and kind of wanting to do the right thing and making sure that patients don't worsen. And so trainees have expressed, that they will follow the guideline and they will give broader spectrum antibiotics because they don't want to get in trouble the next day if, a patient dies or a patient gets worse on the wards, because they often feel like they get blamed for that. So, despite trying to disseminate some of this information, I think people are pretty conscientious of this, but, they're trying to do what the guideline says, and they don't want to get blamed if they go off of the guideline. And so with this whole project, we've run into a lot of challenges. And so, do you want to talk about some of these, Joel?
Yeah, I can proceed.
Okay.
Yeah, during implementation of our quality improvement project, we observed quite a number of challenges. Like microbiology results were not always available during the AMS round. So there's kind of like a gap between lab and the ward and the clinician. So this was quite challenging, which you have tried to address. So there should be bridge the gap between clinician and the lab. You find the results are not in the system. That's why clinician, they'll just keep on prescribing antibiotic. Also, there's other challenge with clinician. They don't have knowledge on how to interpret culture results. So this another challenge. Microbiologists are supposed to provide notes when they report their lab results. For example, when you isolate organism which is methicillin resistant Staphylococcus aureus, they should give interpretation, maybe which antibiotic should be used in this case, what options are available. But that one is missing. Also, we found that clinicians, they were not stopping antibiotic. There were no de-escalation or escalation whenever they receive the results. So this also maybe could be lack of knowledge on clinician on antimicrobial stewardship. Also, at the beginning of when we establish our committee, most committee were not aware of the antimicrobial stewardship. So we had to start training this committee on what is antimicrobial stewardship, what it intended to do, and what is the advantage of the hospital to have antimicrobial stewardship program, because we need to optimize antimicrobial use for better patient care and reduce toxicity. So it was quite difficult at the beginning, but then we tried to have different education sessions just to orient them on antimicrobial stewardship. And also, there's been a challenge on stock out of reagent, but luckily this facility is supported by the Fleming Fund country grant, so they are receiving most of the reagent and consumable which enable them to perform culture and susceptibility. And then our quality improvement project we only perform ward round to only 2 wards. This because of resource constraints. Funding was very small. So we covered only 2 pediatric ward. We could have wished to have more ward covered so that we could gather data from all of facilities and understand better burden of antimicrobial use. And also at the beginning, we had time and buy-in of clinician on attending ward round, even pharmacists. Our ward round is supposed to have pharmacist, microbiologist, and clinician. But at the beginning, buy-out of this AMOS was very low. And time to perform this AMOS round was very little. And also there's a challenge on the stock and availability of antibiotic at the facilities. So there are 2 issues here. Clinician can prescribe antibiotic. For example, let's say clinician is prescribing amikacin, and when you go to a pharmacy, a dispenser will say, I don't have amikacin. I have this and I have erythromycin. So instead of prescribing, giving patient amikacin, will be given erythromycin. So this has been one of the challenges which you have observed. And I think this is contributed by lack of antimicrobial stewardship and the monitoring of antimicrobial use and resistance. So the hospital doesn't know which antibiotic should be included in the therapeutic committee. There's no document which could guide. So one of the liver of this quality improvement, we have antimicrobial antibiogram, which could guide the hospital on their formula of antibiotic to be procured. Next slide. Yeah, so one of the achievement of this quality improvement project, we've been able to establish the local antibiogram, essential for pediatrics. But you can see, for example, ceftriaxone, I don't know if anyone can see. If you see the line of ceftriaxone, majority of the isolate show low susceptibility to ceftriaxone. You could see, for example, Escherichia coli, only 24% of Escherichia coli are susceptible to ceftriaxone, and only 12% of Klebsiella pneumoniae are susceptible to ceftriaxone. Again, Acinetobacter, only 14%. Pseudomonas are intrinsically resistant, but if you look Staphylococcus aureus, only 33% are susceptible to ceftriaxone, and these are commonly used antibiotic. So we don't know yet. This is commonly used, and patients are commonly given antibiotic, but a patient do recover. So do this really patient need antibiotic or not? Or are they having other infections? So maybe antibiotics are given irrationally and further driving antimicrobial resistance. But if you look this percentage-wise, these are percentage of susceptible, percentage of bacteria which are susceptible to different antibiotic. You can see most bacteria have low susceptibility to most antibiotic. Let's look, for example, for Escherichia coli along the column of Escherichia coli. Only amikacin, Escherichia coli are high susceptible to amikacin and nitrofuratoin and the meropenem. You can see, but meropenem is in watch category, but it's quite expensive in our country, so we don't like to rush to meropenem. I can give interesting story of ceftriaxone. Back 20 years, resistance to ceftriaxone was very low. My PhD supervisor did a first study at Muhimbili National Hospital, where he detected ESBL producing bacteria among the bacteria, but susceptibility to ceftriaxone and even to ciprofloxacin was very low. But 20 years later, you see most of pathogen have low susceptibility to ceftriaxone. So we are worrying the trend of meropenem also could be the same. So we have developed this antibiogram and distributed to clinicians, so they could use this to guide the empirical prescription of antibiotic while they wait result of culture and susceptibility. It's a bit challenging because clinicians are used to empirical prescription. So we need to change, we need to have a kind of mentorship for behavioral change, that they should prescribe based on evidence. We've given them this antibiogram, but then they should perform culture and sensibility, and they prescribe based on the evidence. Next slide. So Anneka, would like to take on this slide?
Yeah, so kind of in conclusion, obviously this is a big project that's still going, and I think as Joel mentioned, we've kind of had to address things that we didn't expect we needed to address, and so we're still working on a lot of this. So I think from here, we're planning on kind of continuing our committee education and having the committee members act as representatives to also disseminate this information to their respective wards and start to spread the word a bit more to some of the providers on the ground, and then increasing provider education. We haven't really done a lot of training one of our plans was to do some training with the ward providers on the pediatric ward and do more education on how to read cultures and interpret those and all of that. And we haven't gotten to that yet. As Joel mentioned, with the high rates of resistance to some of these, especially gram negatives, we also he wanted to do a study going back and case reviewing our culture result cases to see what happens to these patients, because as he said, we don't see that like 75% of these children are dying. So obviously they either have some infection that's being treated by ceftriaxone or whichever antibiotics they're on, or maybe that's a contaminant or only part of their story. And so we're trying to sort out kind of what actually happens in real life to these patients and not just in the culture media. And then we're working right now on our emergency department team has started revising the sepsis guidelines and trying to create kind of more specific pathways, for patients who have presumed respiratory disease versus, kind of severe sepsis, hypotension, like undifferentiated needs broad spectrum antibiotics now, and then kind of trying to sort out which patients maybe have sepsis with a likely source versus those who are severely ill or in shock and need more broad spectrum coverage. And then they're also going to incorporate this into the resident curriculum. And then the emergency department in Tanzania is kind of one of the pioneers in East Africa for developing emergency medicine and has had a program now for over 10 years. And so they are pretty well respected within the country and have this association, the Emergency Medicine Association of Tanzania, or EMAT. And EMAT is actually, kind of based at Muhimbili, but they're now starting to, like, the ministry is wanting to expand emergency medicine and has recognized the importance of it. And so they're starting to open emergency departments and train emergency providers all over the country. And EMAT has an app with guidelines for providers to use. And so, our emergency department teams are interested in, once we have some guidelines for how to treat sepsis and use antibiotics and all of that, to put this into the app and start to disseminate it throughout the country. And then just kind of ongoing advocacy. So, one of our concerns is what's going to happen to this program now that, we're almost out of funding, and how to continue people's participation, whether we can get the hospital to pay for some of this, because it's really hard to get people to go to meetings and do all these things when they're not getting any compensation for it, and how to kind of transition that from the grant funding to the hospital or to the ministry on the Tanzania side to start covering some of those costs. So I think that's it for us. So just wanted to thank a lot of our team on the ground, including, these three are kind of our main people in the emergency department. We have our whole committee, lots of people on this side too, like the posters that you saw were made by some of the medical students here. So just a lot of people who have been working on this, and then also to Prachi Singh, one of our ID physicians who gave me some of these slides on some of the background for AMR. So I'll stop sharing and then open it up for questions.
Hi, I'm Sumant. I'm actually the second year PEDS ID fellow at the University of Maryland. We have like ongoing surveillance of blood and other cultures in Mali, and a lot of our antimicrobial resistance data is kind of similar. We have very high rates of ceftriaxone resistance among gram negatives. And our mortality rate among children with confirmed bacterial infections is about 49% over the last 3 years. And I was just kind of wondering, I didn't hear you actually report a mortality rate. I was just wondering what your mortality rate overall was among children with confirmed bacterial infections. Because we also have really significant difficulties in obtaining broad spectrum antibiotics like carbapenems, unfortunately, because I think it's probably a similar system where the family has to go purchase the antibiotic themselves.
Joel, go ahead, Joel. I was going to say, do you know the answer to that?
Yeah, as Anneka concluded in the last slide, we don't know yet the mortality rate of these patients through bloodstream infection. That's why we are going to perform a review, this part of our study, that we found, for example, ceftriaxone is commonly used, but mostly are gram-negative resistant to ceftriaxone. So what happened to these patients? And we don't see a very high mortality at Muhimbili National Hospital for patients with bloodstream infection. So we'd like to conduct a retrospective review of all the data which we have collected. We have more than 3,000 patients with the more than 26% is confirmed bloodstream infection. So we are going to review this data and see what happened to this patient who's confirmed bloodstream infection. What will be the mortality rate? But so far, we don't have the data. But from previous study, which we did at T3, 4, regional referral hospital and Muhimbili National Hospital, we found that mortality of bacterial bloodstream infection was around the less than 20%. I'm not checking my data, but it was around less than 20%. But also, we found that patients with multi-drug resistant bacteria had a high chance of dying compared to those who had no multi-drug resistant bacterial infection. And in some of our studies, we found if patients have positive bloodstream infection, they are likely to die compared to those with without positive culture bloodstream infections.
Thank you. That was really wonderful.
Joel, this is probably a question for you. If you had to kind of list the priorities in order of how you would prioritize them, what do you think is the most urgent need to combat antimicrobial resistance? Is it increased microbiological testing throughout the country? Is it increased like data locally? So basically, like, is it real-time testing that's going to make the difference? Is it being able to have local data to develop the guidelines and the antibiograms, or is it more about having the appropriate drugs for the patients when you need them? What do you think is like kind of the like number one thing? All of them are important, but just curious.
Yeah, I can say all of them are important, but to have microbiological testing are quite essential. We have challenge in diagnosis. So mostly we treat syndromic treatment rather than evidence-based treatment. So right now we need to scale out our lab capacity to perform culture susceptibility. We are happy now. We are performing sensitization in most healthcare facilities. They should perform culture susceptibility. But you know, the major constraint is resources. Yeah, most facilities they can't perform culture susceptibility. So we go back to collect data and to data to help establish antibiogram. But the challenge which we are facing, data we are collecting from this higher, from tertiary and the zonal hospital, but the data cannot reflect the lower healthcare facilities. So it's quite a very difficult scenario. For example, if we need to establish to update our local guideline, we should get data from lower healthcare facilities that be representative to that facilities, because patients which we see at Muhimbili are quite different from patients which we see or are seen at lower healthcare facilities. But again, having point of care testing are quite essential. if you could have point of care testing which could guide the empirical treatment of antibiotic. If patient has markers, maybe indicating for bacterial infection, maybe could benefit from antibiotic. If they don't, maybe marker negative, this point of care negative, maybe patient should not be given antibiotics. So it's quite complex problem we have in the country. I can say all our priority, we're trying to do the needful, what we can do, but it's quite challenging.
Yeah, it almost seems like if any one of those is out of line, you can't really make a big difference in the antimicrobial resistance. I don't want to stop questions, but I do want to point out that there is a link in the chat for the survey. It's a very short survey. It's like 3 questions, but we do value your feedback and we do change the course and lecture series year to year based on what you say. So sorry, Anneka, I think you're going to say something.
Oh, I was just going to say that I think Joel is advertising a little bit for your talk later on sepsis and sort of how to differentiate patients with sepsis and who's more likely to be severely ill. So I think if people are interested in that comment, to go to your talk. And then I just wanted to also just add, like, as Joel was saying, I mean, even at Muhimbili, which is like, you know, they have this grant from the Fleming Fund, like they're one of the sites with microbiology supported. Like we still found out like getting a culture in the emergency department almost never happens because the resources, I guess they didn't have enough culture bottles. So the culture bottles ended up being put in like, I don't know, Joel, where they put them in the lab or they're somewhere like way far from the emergency department. And you actually have to go and like give them like a paper and say like, I want a culture for this patient. And then the person has to bring the bottle back to the emergency department. And so like if you have a patient, you know, who presents septic and is severely ill and you're like drawing all these labs, like no one ever really goes to get a culture bottle like way across the hospital to bring back to do this because it just takes too much time. So, you know, the majority of patients end up getting pre-treated anyway, and then they get a culture later on the ward when they're not improving. So, you know, even those results, it's like, who knows, like maybe they had a different infection that was treated and that's why like a lot of the isolates we're seeing are resistant because that's what's left after, you know, so it's just really tricky. And even in this, you know, what would be comparatively like a sort of well-supported hospital within Tanzania compared to some of these lower level health centers, it's still difficult to do all of the testing and, you know, surveillance and things that you need to just identify a single patient and sort of what's causing their illness. So, and then we didn't really present all of our ward data, which would be kind of more of a point prevalence. Like we only were there a couple days a week on the ward. So we have some data from ward rounds of, you know, what people are doing, but by and large, like when we look at it, it was super rare that anyone ever changed antibiotics. And, you know, a lot of the patients, I think it was like under 50% had a culture result available at the time of rounding. And then even the ones who did, like it was like a handful of cases where it was indicated that people actually like adjusted or, you know, stepped down or stopped antibiotics based on those results. So like Joel said, it's like there's so many things. And I think that's part of the reason why we're like still kind of doing this project, because we have found, I think, that it hasn't been as simple as we thought to like kind of, we're going to go change this and track this and see why people are doing this. And then like start, you know, in like the kind of traditional QI where it's like you find the problem and then you like implement things, because we've like implemented and like nothing's really changed so far. And so we're still kind of in our PDSA cycles, and it's just like a lot to take on. But I think we're moving in the right direction because I think a lot of people are, at least the awareness part has increased. And yeah, so I don't know if Joel, do you have any other thoughts on that, of like kind of how the culture has changed, or if you feel like there's progress slowly being made?
Yeah, there's a minimal. I'm a bit positive and optimistic. It's not easy to change the practice of clinician, especially in our country, where clinician, they are used to empirical prescription. So even in hospital, which is well supported with reagent consumable, you find doctors that don't request culture and susceptibility. And in addition, even to Muhimbili, as Anneka said, you share the lab result, but doctor will not de-escalate or escalate antibiotic. So I wish we are trying our best to do intervention like education. We've poster before Anneka poster, for example, in program which we're implementing this surveillance, we made a poster just to exercise clinician to perform culture and sensitivity and to prescribe antibiotic based on the evidence. But it's tricky. I don't know, we need to check our university curriculum on antimicrobial resistance. Does the curriculum covers all module on antimicrobial resistance? I'm doing this study with my elective with one of my students to see if our curriculum address the issue of antimicrobial resistance. Maybe the problem it starts from the way we train our medical students regarding antimicrobial resistance.
How many years of total culture data do you have?
You mean for this quality improvement?
No, in general, I was just curious.
For the Muhimbili National in total, for last year, we have about 10,000, almost 10,000 culture performed, both from urine and the blood. But I think there are more than that because we haven't included other specimens like pus, wound pus, sputum. So the data which I have are more than 10,000. But for this quality improvement project, we collected like 4,000 blood and urine culture results.
But how far back did the 10,000 go? Like when did the Fleming Fund, like how many years is that? The 3 years, like what you showed in the
that's
slides?
for 1 year.
1 year.
Yes, both the adult and the children.
Yeah, but have you been collecting, like you showed 3 years of data before, but as far as like emanation of Fleming support goes?
We started 2021. No, 2020. We have data from 2020, 2021, and 2023. And so surveillance is ongoing. So this year, end of this year, we have data, complete data for 4 years.
Have you had a chance to sequence? Sorry, go ahead, please.
Hi, thank you for an excellent talk. I'm Julia Johnson. I'm a neonatologist at Hopkins, and my work overlaps with yours a bit, although usually I'm more focused on infection prevention side. But I've been working in India, and again, this is more of a comment than a question, but you know, some of the same barriers that you cited for antibiotic selection and tailoring to therapy are related to lab capacity or just the setup of the facility practices, as you were mentioning, where blood culture bottles were physically located. And I was just wondering if you had incorporated any human factors engineering principles into your approach to addressing some of those barriers, because I do think that would be a good mechanism for really systematically observing those barriers and potentially addressing them without potentially a lot of financially intensive resources needed.
So we haven't really gotten into that too far. And some of these things, like I said, like it took a lot of time for these to even sort of get brought up as reasons. Like even the guidelines, it was like after, I don't know, probably like 9 months of data collection that like our emergency person was like, oh, it's probably because we have this guideline. That's like, we didn't even know the guideline was there. Like no one ever told us that. We were asking, like, why do you think people use so much ceftriaxone? And then like the culture bottle too, like, you know, further down the line, it was like, oh, you know, actually like they changed the policy and like it's really hard for us to get a culture. So I think like that's a great thought, and I think it would be something that we should look into and start to examine some of these drivers a little bit more now that we're able to describe the problem, because I think one of the tricky parts with this, and with a lot of, I think, quality improvement projects, particularly related to stewardship in these settings, is that unlike here, where you can kind of pull a bunch of data and say, like, here's our preliminary data, and now we're going to implement this and see how it changes. Like, we didn't have the preliminary data to start with, so it's a little tricky that we spent a lot of time on that end, and then finally had the data, so that the kind of timeline is pushed back a lot than I think, like, what we think of as starting a QI project in a more high resource setting. And so yeah, a lot of these, like, drivers and things, I think, would be, like, we're at the point now where I think exploring some of those more in depth would be super helpful, and finding specific targets of what may be a really easy fix.
Was there one final question?
I think someone asked about sequencing.
Oh, not
Yeah,
yet.
so I just basically wanted to see if you had a chance to sequence any of these resistant gram-negative organisms, like what type of ESBL, whether it's like a CTXM or something like that.
Yeah, so we've done a couple of studies in the past, and the most common CTXM is ESBL gene is CTXM15, but those are not from this isolate, from other isolate at Muhimbili National Hospital. But interestingly, I've collected some of the from my own study, not as a national part of national whole genome sequence surveillance. I've done sequencing of from few of the isolate. I was interested in looking at mechanism of resistance to carbapenem. These are just sequenced like 10 isolate whom were carbapenem resistant, and I found NDM5 is common mechanism for resistance to carbapenem. So it's quite expensive to perform sequence from this end. Even for those few isolate adjustment for my own interest, but not as national surveillance.
Have you been saving the positive isolates from the QI study, from the 4,000? Well, only the positives, but.
Yes, we have some of the isolate have been stocked. So no, this isolate and Muhimbili National Hospital, so they're part of routine work. So we supported them with storage reagents, and we've been advising them to store this isolate because they're precious isolate for future study. So I don't know. I haven't checked how many isolate has been stored, but I'm pretty sure there could be few isolate stored.
Do you guys mind putting your emails in the chat really quickly? I think there's a few people on the call who have overlapping interests, and it might be nice to connect. And then we're out of time. I do want to make sure that everyone gets their break for those who are continuing on with us.